Hi, everyone. Welcome to another NKF Facebook Live event. Today, we're here to talk about treatment options for COVID-19. I'm Caitlin Engel. I'm a registered dietitian and NKF's Program Development Director, and I'm joined today by a couple of guests that I'd like to introduce you to. First, Dr. Michael Anderson is a Senior Advisor at the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. Little bit of a mouthful. Gina Smith is a registered nurse who is working on COVID-19 monoclonal antibody therapeutics for the National Disaster Medical System at the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. And you guys all know Dr. Joseph Vassalotti, our Chief Medical Officer and Clinical Professor at the Icahn School of Medicine at Mount Sinai. Thank you three for joining us today. So we'll start with Dr. Anderson. We know that COVID-19 vaccines have proven to be very effective in most people at preventing serious disease, hospitalization, and death from COVID-19. But we do know that for some people, especially kidney transplant recipients and those who are on immunosuppressant medication, as well as people on dialysis, those vaccines haven't had quite the same level of immune response. And so it is still possible for people to be infected with COVID-19, especially those in the high-risk population. Since we're currently dealing with a highly contagious Delta variant in the US and cases are rising, can you talk about anything else that kidney patients and other people who are at high risk can do to prevent serious illness, hospitalization, and even death from COVID-19?
Sure. Caitlin, thank you so much. Can you hear me okay?
Yeah, sound great.
My thanks to you and Joseph and the NKF for inviting Gina and I here. We're really honored to be here to talk about COVID therapeutics. And as you pointed out, vaccines are really important. And we are at a point in this Delta surge or this overall pandemic, and the president said it last night, we've got to get more and more people vaccinated so we can get close, if not at herd immunity, so that variants don't have a chance to emerge and we can get back to some sense of normalcy. But as we sit here in September of 2021, you're spot on. We still have patients that either are vaccinated and unfortunately have a breakthrough case. The vaccine was ineffective, they have immunosuppressions on board, or the unvaccinated population. And there's still, unfortunately, tens of millions of Americans that aren't vaccinated. So we're here today to talk about an important COVID therapy. Caitlin, you're spot on. Vaccine deserves energy and attention. I know that the NKF has been talking about vaccine for a very long time, but I brought a couple of slides that Gina and I put together to talk about therapy. COVID therapeutics. So if we could switch to the slides now. So there are my slides. And by the way, that CTR means I'm a contractor. So I'm a contractor for the federal government. It means I don't speak officially on behalf of the federal government. I'm an expert that's a part of this ASPR, the Assistant Secretary for Preparedness and Response. But once again, a physician for 30 years and really honored to be here. Just a couple of notes. This is for informational purposes only, that this is not supposed to be medical advice. And I'm sure, as all the folks on the Facebook know, if you've got a question, your individual, either transplant nephrologist, nurse practitioner, those are the ones that should really answer those questions. Gina and I are here to give you sort of an overview of these really important therapies. So what I want to talk about in my brief time, and then Joseph and I continue the dialogue with Gina and take questions. So what's a monoclonal antibody? We're here mostly to talk about monoclonal antibody as therapy for patients with COVID. How do we think they work in patients that have COVID-19? Of course, one of the fundamental things that we in medicine always want to do is make sure that a therapy we give a patient is as safe as humanly possible. They're really important. Who's eligible for this medication? How do we think about eligibility for patients? And then how the heck do I get it? I've turned positive, unfortunately, or my mom or my aunt has turned positive. What's sort of the process to get these therapies? And then finally, are there other resources? We are in the middle of a really bad Delta surge, and we at the Federal COVID Response at HHS have been working hard to make sure that we get as much information as possible through wonderful webinars like this, but also for making sure that clinicians know exactly what's going on with the monoclonals, so that your nephrologist, your family medicine doc, your nurse practitioner have as much information as possible. So monoclonal antibodies are really an external source of antibodies, just like the natural ones that you produce once you get the vaccine. So you may not have antibodies to this virus that we call novel SARS-CoV-2, the virus that causes COVID. So these monoclonals are actually made in a laboratory. They are given to the patient to fight that acute infection as sort of a temporizing measure. Until you can mount your own immune response, we're going to give these patients antibodies against the novel SARS-CoV-2, the virus that causes COVID, and we're going to give it to a particular subset of patients. It is basically trying to treat the infection with COVID until the patient can mount their own immune response. It is also a really important goal, not only to treat that patient, but to prevent that patient from progressing farther in disease. So that the plan is, maybe you have a cough and a fever, we give you the monoclonals, and you don't progress to getting more short of breath, or God forbid, having to be hospitalized or placed on a ventilator. So the overall goal of these monoclonal antibody therapies is to treat a patient that's turned positive for COVID, to give them some time to fight this virus, and then they have time to develop their own natural immunity. The other goal, of course, is to prevent people from progressing farther and farther in disease. So that's good for the patient. They feel better. It's good for the family. They have their family member back. And I must be honest, it's also good for the healthcare system, because right now, and you can see the reports in the media all the time, our health systems are strained. The hospitals are at capacity. So the more we can do from preventing patients from progressing with this disease, of course, number one, first and foremost, it's good and important for that patient, but it's also good for the healthcare system that right now is just feeling the incredible strain of the influx of all these patients. This is different, repeat, different than a vaccine. This is not, repeat, not a substitute for a vaccine. Every American, in my mind, down to age 12 should get the COVID vaccine. Kids under 12 right now are unfortunately not qualified to get the disease. I'm actually a pediatrician by training, and we're working hard to get the vaccine for kids. But this does not take the role or take the place of a vaccine. A vaccine, and once again, I'm sure NKF has studied that or talked about this a lot, that is the ability to present a very small particle of inanimate RNA or virus, and then the body's own immune system just takes off and develops immunity towards that virus. However, in those patients that, once again, either haven't gotten the vaccine, or for whatever reason they've had a breakthrough infection after getting the vaccine, these monoclonal antibodies are really important. And the data is really impressive. I'm not going to go through my main number of studies, but overall, the studies show these antibodies are safe, and they decrease the need in patients to be hospitalized by upwards of 70%. Once again, good for the patient, good for the family, and good for the healthcare system. So what we don't want to have in the argument is, well, these monoclonals are there, I really don't need vaccine. We need this country to get vaccine. And I know, once again, NKF has been a really important advocate for that. This is just a graphic that I borrowed from the journal Nature that talks about how these antibodies work. Once again, they work, we believe, just like your own natural antibodies do, that they bind to the virus, that prevents the virus from entering the human cell, or then allows the virus to be destroyed by the patient's own immune system. So it's, once again, a temporizing measure for a patient until they can develop their own immunity. And this is the way that we think that these antibodies work. Of course, first and foremost, as I said, we have to make sure that these therapies are safe. And these are under what's called an emergency use authorization. In my simplistic thinking, that means the FDA has said the benefits of these therapies outweigh any potential risks. We're at a time of an enormous crisis called a public health emergency, called a pandemic. And we believe these therapies are going to cause much more good than any potential harm. And we've treated, this is actually slightly old, we've treated over 500,000 patients with an incredibly good safety profile, very, very low occurrence of side effects. But we also continue to study it because it's under this called EUA. And I think Americans have learned a lot more about EUAs over the past several months. We continue to study it to figure out, is it safe? Are there any variations that we have to make to its approval? And I won't go into the the drudgeries of EUA change of it, but suffice it to say that your clinicians, your docs, your nurse practitioners are constantly updated as these EUA criteria change. But the first thing, the most important thing we look at is, are they safe and are they effective? And especially as we have variants come out across this country right now, the Delta variant being the biggest player, unfortunately, we also make sure that these antibodies are still effective against these variants. So what's the U.S. government doing in this? Well, at the time of a public health emergency, once again, the agency that I'm honored to work for, ASPR, can be in charge of getting medications into patients. And we now have two major indications for these antibodies. And Joseph and I can talk a little bit under each of these. To the right on my graph is an important subset of patients. And I want to kind of slowly go through this. On the right is infected patients who are at risk of developing more severe disease. So once again, this bucket to the right, these are patients that have turned positive for COVID. They've had a test that says they're positive. Second, they're in the first 10 days of symptoms. That is really important. The sooner we can get patients into therapy, the better. So a patient, unfortunately, has tested positive and is in the first 10 days of symptoms. And third, is not sick enough to be admitted to the hospital. They don't have a big oxygen requirement. They're not in enough distress to be admitted to the hospital. So this important group of patients, we've got to get these therapies into them as early as possible. There's a 10-day window. Once again, patients are eligible for these therapies. They've turned positive for COVID, first 10 days of symptoms, and not sick enough to be hospitalized. And they have some high-risk criteria that says we're worried you could progress. Age over 65, obesity, diabetes, hypertension, chronic renal disease. There's a list of high-risk criteria that then the clinician says, Mrs. Smith, I really think you should get this monoclonal antibody because I'm worried you could progress farther into disease. So that's a really important set of patients. A couple of weeks ago, actually the end of June now, this notion of post-exposure prophylaxis was also approved for monoclonal antibody therapy. These are patients that have been exposed to someone with COVID. They were in close contact at a dialysis center for a certain number of time or a certain amount of time. They were in a congregate setting like a nursing home or a long-term care facility. And the patient is either not vaccinated or we're worried they wouldn't mount a vaccine response. We're worried that they're immunosuppressed. So now there is this whole indication that we can give these antibodies to those patients who have not yet turned positive for COVID. Thank God, they've just been exposed. And the notion is that we're going to help them not progress to turning positive for COVID. So let me back up 1 second. Monoclonal antibodies are an important therapy. The first important subset of patients that can benefit from them are patients that have turned positive within the first 10 days of symptoms, or the second important group of patients is those that have been exposed to a patient that is known to be positive. And the reason I'm so glad my friend Gina Smith is here, she's a nurse that is not only an extraordinary leader in disaster response, she's helped set up monoclonal antibody centers across this nation so she can help us answer any questions that the Facebook Live may have. So once again, I mentioned the criteria. On the left shows you the criteria of high-risk patients that can benefit from these therapies. Age over 12, has tested positive for COVID-19. I'm going to say it another dozen times, is in the first 10 days of symptoms and has a high-risk criteria. The reason I want to keep emphasizing the first 10 days of symptoms is it's important that people get tested early. If you wake up with a cough or a fever or muscle aches, it is so important that patients don't just kind of, well, I'll get to that Monday because I've got a lot of weekend plans, or it probably can't be COVID because I'm a really strong person. We've got to have robust testing that then ties to patients seeking out these monoclonal antibodies. So once again, Joseph and I can talk maybe a little bit more during the dialogue, but suffice it to say, we've got to get patients tested early, and we've got to get patients into these monoclonal antibody therapies within that first 10 days of symptoms. So on the right is, okay, so I'm in Cleveland, Ohio, I'm in Los Angeles, California. How the heck do I get these therapies? Well, first, You unfortunately, for that first bucket of patients I talked about, have to be positive for COVID in the first 10 days of symptoms. This is a referral from your healthcare provider, just as if I were to write you a prescription for an antibiotic. So you've got to have touch, be it a telephonic visit or a video visit with your healthcare provider. And then we're going to show you an infusion tracker that help figure out where these centers are. I don't want to say it's good news because it's news in the middle of a very bad pandemic, but we've been very heartened to see more and more centers opening across this nation. And the United States government is in charge of distributing these antibody therapies to these centers, and the orders have just kept going up and up. That's a little bit sad that we're still in the middle of this pandemic, but it's also reassuring that more and more clinicians are now starting to use these antibody therapies to prevent people from getting sicker. There's so many lives that we can still save with these therapies. I think they're a really important tool in our clinical armamentarium. So how do you find it? There's a couple of different ways. Number one, have a conversation with your care provider. In my mind, that conversation with your nurse practitioner, your family medicine doctor, your nephrologist is so important. Where are the monoclonal antibody therapies in your region? Is your particular hospital doing it? Is your particular medical group doing it? And this doesn't just have to be in the hospital. I didn't put a slide on it. The majority of these antibodies are administered intravenously, IV, but they can also be administered as a shot subcutaneously. So we've seen centers across this nation figure out, okay, what is the area that I can do it in? What is the staff I can bring to help take care of these patients? How do I need to administer them? So first and foremost, I would say have a conversation locally with your folks. We also have, and we can make these links available, an HHS Protect public website that says, I'll keep picking on Cleveland. In Cleveland, here are the infusion centers. And then we've also partnered with NICA, the National Infusion Center, that have really set up dozens and dozens of centers across this nation. So there are a number of resources if people want to get this therapy. But I would start first and foremost, like everything, with a conversation with your care provider. So what does the treatment involve? And once again, Gina has actually helped hundreds of patients do this. These patients typically have an IV infusion, although as I mentioned, one of the monoclonal antibodies, the Regeneron product, can be administered through subcutaneous infusion. There's no cost for the medication. The United States government has purchased all of these medications, so there's no cost. The facility that administers it may charge an administration fee, but we've seen Medicare, Medicaid, and private insurance cover that. So we get asked often, okay, so what is the cost of this? There's no cost of the medication, once again, because the federal government has procured the medication, and then it's up to the individual center what they're going to charge for administration. So once again, it's really important to know what your local resources are to get these therapies. It happens in many different settings, as I imagine. I'd say the process is about 2 hours. 3 hours would be an outlier. Patients come in, they get screened. If it's going to be done intravenously, they get an IV. If it's going to be the subcutaneous route, they get a shot. And then they're monitored, just like when you get a vaccine, they're monitored for an hour afterwards, just to make sure that the therapy is going well. There's no allergic side effects. Once again, just like when you get the vaccine. And the part on the right is also really important, that you are positive for COVID if you get this therapy. That means you still have to self-isolate. You still have to follow the CDC. It's not a magic bullet. You no longer have to follow the CDC guidelines for a positive patient. So make sure that you haven't had symptoms for 10 days before you go out. Make sure you haven't had a fever. Once again, Gina can talk specifically a little bit more to that. We also have a website that I think is really important for people to know. So if you're advocating for yourself or for a loved one or for groups of patients, we have compiled a lot of information, not only on the monoclonal antibody therapies, but also on other research trials, on other medications. There's been a lot of innovation in trying to improve the outcome from COVID. So this is combatcovid.hhs.gov. The website is combatcovid.hhs.gov. And there's a subsection on monoclonal antibodies that has patient handouts, testimonials to folks who've received these therapies. I was just saying before we came on, a dear friend of mine in Ohio unfortunately turned positive, and I spent the last 12 hours finding her in an infusion center. Thank God, even as we speak, she's at that infusion center, and I know this is going to be very effective for her because she has a couple of high-risk sort of comorbidities, if you will. So combatcovid.hhs.gov is our one central landing page for everything. So with that, Caitlin, that was sort of my long-winded answer to. So there's other therapies, Dr. Anderson. Could you tell us more?
That was fantastic. Thank you so much. And this is very exciting. I think it gives a lot of hope for people that there's other options out there. So just to clarify, there's monoclonal antibodies that you can receive as a prophylaxis or a preventative measure, and then those that you can receive as treatment for COVID. Is there any difference patients need to know about between the two? And just one more time, can you explain the difference between those two and vaccines?
Yep. So I have a graphic that I feel bad I didn't put in, and it's sort of the progression of it. It's a little bit more medical. I wanted to keep it more high level. If you think about the number one goal is to prevent anybody from ever getting this terrible virus again, and that's vaccine. Vaccine, whether it's any of the 3 EUA approved vaccines, that's going to help patient develop antibodies and develop immunity to this horrible virus. So vaccine has to be the number one criteria. God forbid you spend a weekend at a cabin with somebody that you learn the next day turned positive for COVID. You are now an exposed individual. You haven't developed the disease, thank God, but you're an exposed individual. You were in close contact with someone that has COVID, and you yourself are at risk for either you didn't get the vaccine, which would be a tragedy, or you're on immunosuppressive medications, or you are chronically ill. So you may not mount, even though you've had vaccine, a normal response. So this is the post-exposure prophylaxis. Those patients, once again, under the care of their doc, can get the monoclonal antibody to prevent them from turning positive for COVID. So that's section 2. Section 3 is an unfortunate patient that has turned positive for COVID. They've got a sore throat, they've got muscle aches, they've got a fever, they get tested, they are positive for COVID. And we want to prevent them. We can't prevent them from getting COVID, unfortunately, that's happened. We want to prevent them from progressing further to needing a ventilator or being in the intensive care unit, God forbid, and God forbid dying. We want to prevent that. So that subset of patients qualifies for the same monoclonal antibody therapies. And Gina's going to hold me correct if I outline the three sort of tranches. Gina's nodding violently, so that's good. If my nurse tells me I feel good.
So Gina, we mentioned a little bit that people can go to that website to get the treatments. They need to go through their doctor. Is there anything else people need to know about how to access this? Should they need these treatments? And can you tell us a little bit about what people can expect when they go to receive those treatments?
Sure. So the goal is to have people contact their provider, but generally the provider may be contacting them once they've received the positive test results, right? But if there is any break in any of that and they're not able to, we advise them to go to the COVID site. Are the slides being shared? If they are, all of those links will be in there. Otherwise, we can
I don't think they're shared right now, but we are sharing in the chat, in the comments, we'll have a link to a flyer where they can access that information.
Perfect. So going to that site, they could receive a lot of information regarding the sites that they can go for infusions or questions that they may have. A lot of them are FAQs, or that there'll be answers to questions that they may have. There's also a phone number there, and I've actually, Dr. Anderson calls it secret shopping, but I actually did that. And I called because I wanted to be able to understand what was happening on the other end, and gave my answers. And I told them that I was actually part of the therapeutic group, but I wanted to understand it. So I'm going to answer them as if I was a patient, because I didn't want them getting all nervous that I was a person with COVID and not taking the right direction. So they walked me through the entire process. They ask you a bunch of questions. When your symptoms started, did you have a positive COVID test? All questions like that. They'll ask you where you live, what your age is, and they'll actually start asking you questions so they can see if you meet the criteria. Once you do meet the criteria, they will tell you that you are eligible for monoclonals. If you give me your zip code, I can tell you some options for you. And so those are listed, and they can let them know that. Now, if their provider is doing this, the provider will be able to send the order or a fax or referral for them. But it's important for patients to know that they have those options to find out that information too. And I always encourage people to be proactive. When we first started this, a lot of providers knew nothing about monoclonals. And I also had a friend that I said, hey, this is what I want you to do. I want you to call your provider and tell them that you know about, and I'm texting the names of them and everything else. And that provider was very open to the information, looked into it further. We'll fast forward, that gentleman was referred to an infusion site. So it's important for us to give information to the patients so that they can be proactive and present it to their providers as well, that this is something they're interested in. Once that happens, they're scheduled to come in to receive an infusion at that location. They will be told, generally they're positive for COVID now, so we need to make sure that the person that either drops them off or brings them knows that they're not going to be coming into that treatment area. So they make arrangements for that. People will all be in personal protective equipment, full PPE when treating them. We've had sites where they're all in one room. We've had sites where they're all in individual rooms. And they're all in one room because it's cohorting. They all are positive. So they're not going to expose anyone else. And us as the providers or the caregivers are in PPE. Then someone will go over the questions again, most likely grab a set of vital signs, blood pressure, and temperature. The one that they're looking the most for is the oxygen level, because if their oxygen level is too low, they may end up taking a different route in their care. And if their oxygen level is low and they're dependent on oxygen, then they may not meet the criteria. So that's one that is generally always checked when they come in. Someone will hand them a fact sheet, which is very similar to what you're posting. And it's for the patient and the caregiver so that they understand what they got and the directions for that. If they're getting an infusion, they will be told that they're going to have someone start an IV line, an intravenous line, which is generally one needle stick, and an IV bag will be hung with the antibodies in it. That can range from a very small bag, a 50 cc bag, all the way up to a 250 cc bag, depending on the site or the provider. But the amount of the antibodies is the same. It's just the volume of fluid that's with it. That will hang, and that will run over 20 minutes to an hour, depending on how much fluid that was in. They may or may not have their blood pressure and vital signs checked. It depends on the site. There are a lot of sites that that's what they're used to, and they want to keep checking their vital signs. Or you may not have them at all. People will just ask you, how are you feeling? Do you have any shortness of breath? Are you having any rashes? Anything that would give an indication that you might be having a slight reaction or a reaction. If that happens, they may just shut off the IV and hold off for a few minutes and then start it at a lower rate, depending on what your symptoms were. They'll have medical equipment there if you do have an allergic reaction in order to treat that. Once your infusion is done, you may stay in the chair or the stretcher that you were in, or they may say, okay, we're going to move you to an observation area, which may be in another room. So you can observe either in that location you're at or move to another room. That will always be an hour. That won't be any less than an hour. And that's to make sure that there is no allergic reaction to the antibodies. And the reason why they pick an hour is because they really, in studies, haven't really seen much of a problem after an hour. Actually, they haven't seen many reactions that needed to be treated, period, which is a really good thing. So after that hour, someone will come over, ask you how you're doing, remind you that you're still positive for COVID and that you still have to isolate for the 10 days. and, stay away from others, etc. If your symptoms happen to get worse and you end up with respiratory problems or chest discomfort or any of those type things, which is maybe indicating that the COVID is progressing, then you're asked to contact your physician or go to an emergency department. And then we always tell people to spread the word that this is available. So to let others know.
Thank you.
Now, I just want to, one other thing that I wanted to mention was this doesn't have to be in a hospital. Ours was in a tent, a very large, you can call it like a party tent, the ones that people have for weddings and stuff. Maybe not as nice, but it could be outside of an emergency department. It could be in a Walmart parking lot. It can be in there's a Crush COVID mobile, which treats 1 or 2 people that you might see on the roads. There are individual ambulances that go out and infuse. There are infusion centers. There are people that do home infusions, as well as people that are able to get infusions at dialysis centers. So it's a wide variety of venues that you can go to in order to receive it.
So you shouldn't worry that if you don't live close to a hospital or clinic, that it will be hard to act. There's a treatment available for you regardless of where
there are many options available.
That's great.
Even if it has to come to you, right? So
yeah.
Those, far distanced areas, they have to get it brought to them.
That's great. So Dr. Vassalotti, as you know, we have a lot of people watching who may not be kidney patients themselves, but are care partners or loved ones of a kidney patient. What should they do if they're living with someone or in close contact with someone who may be at high risk, for a kidney patient or a transplant recipient, and they are exposed to or they have COVID?
I want to thank Dr. Gina for really great information here. Today is September 10th, 2021, and I'm going to just take a little second here to frame the answer to this question. Tomorrow is the anniversary of September 11th, and there were times I was living in Manhattan at that time, and I didn't know what the future was going to be like. And I think now that we're with the COVID-19 pandemic, which is ongoing, but it's changing, I think I want to give you hope. I want to give the people here that are listening hope. We're going to get through this. We're in this together. We're going to do everything we can to help you get through this. And I want you to think about vaccination, testing, and treatment. We've talked a lot about vaccination and testing, and I think this really emphasizes the importance of testing. And kidney patients sometimes feel fatalistic about this virus, that maybe you won't be able to see it through if you get infected because of all you've heard in the press about it. And this is so exciting that we have monoclonal antibody therapies that something like 70% is what Dr. Anderson said, effective in reducing severe infection and reducing the risk of hospitalization and support for ventilation or a supplemental oxygen. So what a great opportunity that we have. And so I think that if you're a caregiver of someone who's at risk with kidney disease, treated with dialysis, or a kidney transplant recipient, you want to make sure, of course, that you're vaccinated if you can be vaccinated. If you're old enough, you want to make sure that your household contacts are vaccinated. I think the point about early testing Dr. Anderson made is very important, because you want to be tested yourself or have your contacts tested, because if they have COVID, they may be able to access the monoclonal antibodies themselves. Or what's really new that we learned from Dr. Anderson recently is that if you're living with a patient who's treated with hemodialysis and you become infected, they may be in turn a candidate for the monoclonal antibody therapy, not because they're infected, but because they were a household contact of a person who is infected. So the monoclonal antibody treatment is a therapy for positive COVID-19 tested patients with symptoms, but it's also a preventative, just like the vaccine, but it's only for those who have exposure. And I think most of the kidney patients listening should be candidates for these monoclonal antibody therapies if they're, I think it's age 12 or older. and that this is something I want you to think too about. Let's work together. Let's see this through. So get everybody in your sphere of influence vaccinated that you can. And also, I can't tell you how many people have told me that they tested positive, and the first thing I said was, get the monoclonal antibody therapy because you want to do that within 10 days of the symptom onset. So if you're a person living with kidney disease and you interact with other people, or if you're a caregiver and you interact with other caregivers of people with kidney disease, it's important that you let them know if you hear about a positive test. Did they ask their doctor about the monoclonal antibody therapies? Can they access them? And I think it's important that you know that the dialysis clinics do offer them. Some of them do, but if your dialysis clinic doesn't offer them, I don't think it's realistic for us to expect every single dialysis clinic in the whole country is going to offer monoclonal antibody therapy. So if they don't, I'm sure there's another way that you can access the monoclonal antibody therapies. So that was a long-winded answer, but I hope that's helpful for everyone.
Mm-hmm. That
Hey,
is
Caitlin,
helpful.
can I just add one thing on?
Yes, please.
I want to add something to both what Gina and Joseph said, and that is testing. And I agree that, and I mean, ideally you get vaccinated and we never have to deal with this, but we know that that's not always the case. I agree. We're all rowing in the same direction, right? So we as a patient advocacy group, I'm so appreciative of NKF. We as clinicians, we in the federal response, I've also been really impressed how the testing companies have stepped up and want to be a part of it, because the testing companies have a really tough job because testing keeps going up, appropriately so. But oftentimes, if there's not a clinician making the phone call, the testing company is somehow informing a patient that they're positive, and the testing companies have really engaged with. But by the way, here's the website, or by the way, in Pennsylvania, here are the local places. So I agree, we're in this together. I mean, sometimes it feels like a very fractured nation, but when I meet great folks like on this webinar, I know we're rowing in the same direction. Even the testing companies want to say, I don't want to just hand somebody a positive test. I want to hand them a positive test. And Joseph said it, I want to hand them some hope, because it's been a really horrible 19 months now. And I think these therapies do offer that. They offer hope.
Yeah, that's very positive. So to go back, I'm going to shift over to some of our audience questions, because I know we have a lot of them coming in, and keep asking them, everyone. If we don't get to your question live, we will respond to it in the comments. So I don't want people to worry that we didn't get to all of them. But can someone, either Dr. Anderson or Gina, touch on, just reiterate who is eligible? Ellen asks, or I'm sorry, not Ellen, Susan asks, she's an individual who has one kidney, and would she be eligible for the monoclonal antibody treatment because she just has one kidney?
Yeah, I'll let Gina back me up. If unfortunately you were ever to turn positive for COVID, that cohort of patients that it turns positive, we want to prevent moving forward. As a clinician, I wouldn't consider that a high risk criteria. It's up to your individual dialogue with your care provider. And Joseph's good point about this new sort of frontier of exposure. If you were exposed to somebody with COVID and we were concerned that you couldn't mount a response, I think your clinician could make a very strong case that you're high risk. Gina, would you support?
I absolutely agree with that. And that's why when this first came out with the emergency use authorization, there were very rigid eligibility criteria. And we're very thankful, but the FDA later came back and put that end clause in there. And that end clause is key. If you're a provider, feels that you are at high risk of your illness progressing or possibly death, then yes, you are eligible. So your answer is an easy yes.
Yeah.
So the clinician has discretion, then, in other words.
Exactly. Yep.
That's good. So anyone who is concerned or thinks that they might be eligible, they should just raise that question with their doctor as soon as they find out that they're positive or that they maybe have been exposed.
Mm-hmm.
And often, and Joseph takes care of patients too, as often sometimes the patient educate us, like, by the way, this is a new and important therapy. And I think that the clinicians can learn a lot from patients that are, educated and deeply learned in a particular topic.
Great, thank you.
Yeah, and I know
Go ahead, Jim.
I've heard from patients that a number of them have told me that their primary care doctor wasn't aware of the antibody therapy until they discussed it with them. So I think that's a really important point.
Yeah, and we'll just remind everyone we're sharing those resources in the chat, the FAQ, the links to the sites. So those are great resources that you can bring with you to a conversation with your doctor or share via, telemedicine conversation if they aren't familiar with these therapies.
Yep. And in those sites, there's sections for a provider, and then there are sections that are directed towards a patient or a family caregiver. So yeah, you have that option.
Great. Another question is, how long do the monoclonal antibodies remain effective in your body?
Yeah, we think they have about a 4 to 5 week efficacy. So once again, it is buying time. It is attacking the virus, like I saw, or like I gave you the graphic from the journal Nature, and it's trying to just fight this virus and get rid of it while you heal and recover. It does not mean that you shouldn't get the vaccine. You should get the vaccine after your illness has waned. So this is really, I don't want to say buying time, that sounds too superficial, but it is really an acute right now therapy to help you feel better and stop you progressing. But it's not much longer than 4 to 5 weeks of efficacy.
Great, thank you. We have another question from Bridget, and I think we've clarified this, but let's just clarify it one more time. She asks, she's a kidney transplant recipient, and she asks, do you have to have COVID in order to get that monoclonal antibody treatment? So do we want to reiterate again the preventative opportunity there?
Yeah, we're still learning together. So it's called PEP, post-exposure prophylaxis. It means, thank God you haven't turned positive for COVID, but you have been exposed to somebody that's turned positive. And I don't know why I keep thinking about going at a camp out or something. You've been, and the CDC has very strict criteria of, what do you mean by exposure, doc? It's how far away you were, how long you were there. There's really strict criteria that the clinicians should review. But that patient, indeed, if you've been exposed and your caregiver thinks, I'm a little concerned, you're a chronic dialysis patient, or you've been on immunosuppressives, or you got the vaccine, but I'm still worried about you, that patient qualifies.
Yeah, can I add something too? Well, go ahead, Gina. You were going to say something.
I was going to add something as well. So you do not have to be tested for PEP, right? That's an important thing. So if you're symptomatic, yes, you should be tested, right? But if you're not symptomatic and you've just gotten the exposure, there is no reason to be tested.
And I
just
think
your exposure is enough.
And I think a lot of kidney transplants are worried about the immunosuppression reducing the efficacy or the protection that they receive from the vaccine. And I would say, just summarizing the literature, about 40 to 50%, and based on the antibody response to the vaccines, which is, has limitations, but there's about a 40 to 50% response compared to the, more like 90 plus in the general population. And there is also, with that third dose of the Moderna or Pfizer mRNA vaccine that was recently recommended by the CDC's ACIP, that 40 to 50% goes up to about 70%. So if you're one of those people that's worried because you don't have an antibody and you have a kidney transplant, this is something to really keep in mind, that if God forbid, and we don't wish it on you, get COVID-19 infected, right away, please try to access the monoclonal antibody therapy. And also, if you get COVID-19 before you get your third dose of the mRNA vaccine, I think from what I understand, it's recommended you wait 90 days before you receive that dose. And I think that's probably worth mentioning, that you should still get the third dose, but wait. I think it's 90 days, and it looks like Dr. Anderson and Nurse Gina are verifying that. So please, if you're a kidney transplant recipient and you received an mRNA vaccine, please get another dose of the same vaccine, and please think about this as your contingency plan for if you get infected.
Well said.
That's great. A follow-up question related to the boosters that came through is, would a kidney cancer survivor be a kidney patient that's a candidate for a booster shot?
I think, I mean, I could take a shot at this. I think most likely, it does, I think that CDC's ACIP talks about active treatment for cancer as one of the criteria. So I think, again, this might be a judgment call. Do you have active immunosuppression for the cancer? That would be something that we would have to ask. And, I would say that it might be worth a conversation with your oncologist or your primary care clinician about, for me, should I have a third dose of the Pfizer or the Moderna, the mRNA vaccine? And there's no recommendation for the J&J right now because there's not enough data, but there may be.
So if you're not sure if you're a candidate for a third dose of the mRNA vaccine, the best thing to do is just to contact your clinicians to learn more about your individual situation. Another question from Barbara, and I know we're running short on time, so we'll maybe ask one or two more and then do some closing comments. But Barbara is wondering if, the immunosuppressive medications can make your vaccinations less effective. Do they have that same suppressive effect on the monoclonal antibodies?
I'll take a stab, and then I'm sure Joseph will have, and Gina as well. We don't have any data that the monoclonals are less effective in patients on immunosuppressives. And I think about it simplistically. We're giving you an antibody. It's going to attack the virus because if you turn positive, you've got active virus in your system. And it is not the typical immune response where your T cells and your B cells, we're just giving you exogenous or outside the body antibodies. So there's not data, but just from a physiologic perspective, I don't think that there's going to be, I don't believe there's a major impact on the efficacy of the monoclonals based on immunosuppressives. And, there's some reassurance in this pandemic, and there's also some just, oh my gosh, that we iterate and we learn each and every month, and things will change. Things, just back to the great notion about boosters. We're figuring this out as the data comes in month after month, and the immunosuppressive role may come into favor. But I just, from a physician standpoint, I don't think they're going to affect the monoclonals.
Yeah, I agree. Yeah, I think, a virologist or an immunologist might be able to comment more eloquently on this, but just think about how it works. The vaccine delivers the spike protein in one way or another. So your immune system builds immunity to that, develops an antibody, develops cell-mediated immunity, and what we call killer cells, and there's some memory immunity too. That takes time, and if you're immunosuppressed, that might take longer or it might not be as robust, right? This treatment infuses the spike antibody too. It doesn't wait for your body to develop it. It infuses it into your body intravenously or subcutaneously under the skin, depending on how it's given. So it would make sense that immunosuppression wouldn't affect that. But of course, there's going to be data collection on this, and we may learn more as time marches on.
But at this moment in time, we're very optimistic that it's an excellent treatment option for either prophylaxis or treatment for our kidney patients that are exposed or have COVID-19.
And I don't want to put Gina on the spot. I know you've got a couple of questions to get to, but Gina and I, as I mentioned, we deployed to a center that we stood up on the West Coast, and Gina had several patients, and sometimes it takes some conversation or convincing or getting members of the family to help figure out, is this the right therapy? But Gina and I had several patients that walked in feeling just, this virus can just knock you down. And after the therapy, like, they weren't doing, a jig and dancing out the door, but they came back and said, wow, I felt so much better afterwards. And, if they're hearing it from their own members of the family or members of the community, just did such good things for our efforts in California. So Gina, I don't want to put you in the spot, but it's just so heartwarming to hear those stories of patients that felt better.
Agree, and many of them use the word hope. when they found out, this was at the very beginning too, with all these diagnoses, and when they found out that they were positive, they thought the absolute worst was going to happen, and that there was nothing that they could do. And this came right from their stories, that there was nothing they could do except sit and wait to see if it was going to happen to them, and that they, to see if they were going to be hospitalized and on a ventilator and perhaps die. And receiving these antibodies when they came in, they were excited because they said that it brought them hope, that they weren't just sitting waiting, that they were doing something about it. So I absolutely agree. And we heard those stories over and over again. And one more thing I just want to add, because when in the tents, we had a lot of time to talk with a lot of these patients during their hour of observation and such. And there were some that their number one concern was, well, we're talking about vaccines coming out, and now we're telling them that they have to wait 90 days after they get the monoclonals for the vaccine. And they're like, well, maybe I shouldn't do this then, because then I will have to wait 90 days for the vaccine. And it was a really hard thing to explain to them. And I got better at it as time went on, but essentially the antibodies that we were infusing could start their work right away. And the reason they were positive COVID, the reason why they wait 90 days, which Regeneron really helped us understand, was that the thought is those antibodies that we treated them with might try to break down the vaccine and attack the vaccine and make the vaccine ineffective. So if you wait long enough until the antibodies, the numbers of them and the strength of them break down a little bit, then you give the vaccine. And people felt much better about that, because it would have been sad if they just didn't get it just so that they could get their vaccine when it came out, and that they were positive. So we've all learned.
That's great. You actually just answered one of the questions that I had teed up. So fantastic. So we have one more question. Yeah, one more question, and then we'll wrap up because we're almost at an hour here. So Carrie asks, she's had previous allergic reactions to the COVID vaccines. Is it more likely that someone who has had allergic reactions to the vaccines might also have an allergic reaction to the monoclonal antibodies?
I'll take a stab and see what Joseph and Gina say. I don't think so, because as Joseph eloquently pointed out, they're both anti-COVID, right? They're both attempting to get rid of this terrible virus, but they're different. And the vaccine is different biology and different technology, and the antibody is, just as Joseph said, it's just the antibody, the spike protein to kill this bloody virus and get it out of your system. So I don't want to minimize the risk, because I think if I had that, I would be very careful that if I got the monoclonals, folks knew, like, I do have allergic reactions and stuff. Mm-hmm. So keep an eye on me. But I think of them as different. They're different classes of medication. So I don't think it necessarily puts you at higher risk. It would just, I would be cautious if you do have to get the monoclonal, I would be just very cautious.
Yeah, I agree with that completely. I mean, we don't know for sure. Of course, you should probably see an allergist or an immunologist, or of course your clinician to help sort this out. But there's no reason to think it would be allergic just because you're allergic to vaccines. There are vehicles in vaccines too that they use to suspend the vaccine, and there are different elements which don't exactly roll off the tongue, but sometimes the allergy is to that element. And so I don't understand the monoclonal antibodies to know if the vehicles are the same vaccine and the monoclonal antibodies, but there's no reason to think that they would be. That's another thing that may be worth talking about. And I think one more thing I would say is there are different brands of the monoclonal antibodies, different types, which the two of our panelists are experts on that. And from where I'm sitting, I would defer to others, about that, and I would just try to get whatever's available. But for you, actually, it might make a difference. This might be worth, understanding in terms of which one of them is going to be least likely to be immunogenic or create an allergic reaction. It might make a difference for you, but in general, for most of our listeners, I don't think, to me, it would make a difference. We just want you to receive the monoclonal antibody therapy.
Great point.
Fantastic. Well, I think we are about out of time, so I will just offer this opportunity for each of you or any of you to provide, any closing statements or any final reminders to our viewers, and just remind everyone watching. I know many of you asked questions that we didn't get to, but we will respond to those in the comments. And we're also, provide links to the resources that were mentioned during the presentation today. So Dr. Anderson, how about we start with you with any closing comments?
We'll go alphabetically. That's terrific. I just want to thank NKF for inviting us to your forum. And I think that the only way we're going to get through this pandemic is to work together. And that's patients and clinicians and the federal government and pharmaceutical industry and academics. That's how we're going to get through. And it's just information sharing and learning together. Joseph said it much more articulately than I could. This is hope. This is a very challenging, difficult time. The Delta surge is just taxing us. I'm a pediatrician, as I mentioned. I'm in contact with children's hospitals all the time that are just feeling the tension of this Delta wave. But these therapies do provide hope. So I want to thank you again for helping us get word out, for the excellent questions from the audience. And as we continue to work through, we're gonna figure this out. We're going to get through this together, and I'm just very appreciative of your advocacy for your patients.
Gina, anything to add?
I don't think I can match that. Just use the resources that are out there. There's so many out there, and hopefully they'll empower you to get your hands around this if you do end up getting COVID, which we hope that you don't, or others that share the information.
Thank you. And Dr. Vassalotti?
Yeah, I'll be brief. I want to thank Dr. Anderson and Nurse Gina and Caitlin, you two, for very capable moderating here. And we want to give you hope. We want to help all of us get through this together. And we're looking forward to a partnership with HHS and ASPR to continue to help educate about treatments and combating COVID. And the future is uncertain, but the past should give us hope. And I think I'm very much looking forward to ongoing interaction. And we're going to have a professional education next month, I think, with Dr. Anderson and perhaps Nurse Gina and others, and we're very much looking forward to that.
Thank you. Thank you all for joining us today, Dr. Anderson, Gina, Dr. Vassalotti. Thank you for your excellent comments and expertise. And to everyone watching, thanks for joining us. And we will get back to your questions as soon as we can. And everyone stay safe and talk to your doctor if you have additional questions. Thank you.